Welcome to the webinar, PDPM Collaboration, the Non-Therapy Ancillary Clinician Pharmacist Approach. This webinar has been approved for 1 hour of continuing pharmacy education and continuing medical education. Pharmacists will complete their continuing education through the American Society of Consultant Pharmacists, and medical professionals will complete their continuing education through the Society for Post-Acute Long-Term Care Medicine. Directions will be discussed at the conclusion of this webinar. To begin, it is a great pleasure to welcome today's webinar speakers, Dr. Walter Lim and Dr. Aaron Foti. Here you can find Dr. Lim's biography. We will also hear from Dr. Aaron Foti. The speakers disclose no financial conflicts in regard to this activity. These learning objectives will be discussed throughout the presentation. We will kick off this webinar with a few questions to gauge the audience. So our first question is going to be, what does PDPM stand for? Please take 10 seconds to think to yourself, what does PDPM stand for? Is it prescription drug payment model, prescription-driven pharmacy model, patient-driven payment model, or the patient deciding prescription model? The correct answer to this is C. PDPM stands for patient-driven payment model. We ask this question because we feel like there's a lot of acronyms that are flying around and it becomes a tongue twister, but PDPM is going to be the patient-driven payment model. When will PDPM be implemented? Is it September 15th, 2019, October 1st, 2019, December 15th, 2019, or January 1st, 2020? Again, please take 10 seconds to think about this answer. The correct answer is October 1st, 2019, and this is a hard transition. There will be no transitions or implementation phases. PDPM will be implemented on October 1st, 2019. And then our last question is more of a self-reflection. How prepared do you feel for PDPM? Do you have no idea what's going on? Do you know a little but still confused? Are you feeling confident but want to learn more? Or are you feeling very prepared? Bring on October 1st. And to this, there's no right answer. We at ASCP, we have been producing a series of PDPM webinars to help all of our members feel more prepared. So if you've answered to any of these, it's great that you're here today so that you can continue to learn about this upcoming implementation. And with that, I would like to kick it off to our first speaker, Dr. Lin.
Thank you, Bree. These are exciting times for our industry as PDPM represents the biggest change in skilled rehabilitation reimbursement in over 20 years. Our current reimbursement system, RUGS-4, had its genesis in the Balanced Budget Act of 1997 and is largely a fee-for-service payment system to our facilities. Essentially, the more therapy our patients got, the more our facilities got paid. Over the past decade, many industry observers and CMS have increasingly recognized that this fee-for-service system distorted incentives and encouraged the over-provision of therapy services rather than focusing on the whole patient. As a result, CMS is now launching PDPM on October 1st, 2019, just a few short months away. PDPM is a new payment system for skilled rehabilitation that is based upon the clinical conditions and functional status of our patients at the time of admission and rewards high acuity care rather than essentially just the provision of therapy services. Put simply, PDPM is probably the most disruptive reimbursement change to our facilities that many of us will see in our professional careers and puts increased focus on all disciplines so that we can help our facilities take better care of more complicated patients, including medical staff and pharmacists. So Next slide, please. In terms of the PDPM goals, I know this webinar is focused on the brand new component of PDPM, a component called NTA, which we will discuss in detail. I know there's also an ASCP webinar earlier this month on an introduction to PDPM, but I think reviewing the basics of PDPM before diving into NTA will help level set everyone so that our discussion of NTA will make more sense. In terms of PDPM goals, CMS had three main goals when it launched PDPM. One was to improve payment accuracy and appropriateness by focusing on the patient rather than volume of services provided. And essentially, CMS wants to base payments on clinically relevant factors and not just primarily on the amount of therapy services provided. CMS also sought to significantly reduce administrative burden on providers. There will be fewer MDS assessments under PDPM than under RUGs. Essentially, there are only two now. The 5-day assessment, which sets the payment for the entire stay, unless an interim payment assessment is completed, and those are optional. The other mandatory assessment is a discharge MDS assessment, but gone will be the 14, 30, 60, and 90-day MDS assessments. And as a result, CMS projects a savings of billions of dollars over the next decade in terms of reduced administrative costs. And lastly, CMS says that it was seeking to improve SNF payment accuracy by reimbursing higher for higher acuity patients. And they want to do so without increasing total Medicare payments. So compared to RUGs, PDPM will be a budget neutral change. I think what's important here is that if history is served as guide, care follows finance. And so the ways our facility is paid will dictate their behavior, and we can expect that if they're being paid more for higher complexity patients, they will accept higher complexity patients, and we as medical and pharmacy staff will be an important part to take care of these patients. So compared to RUGs, PDPM has 5 components. RUGs has 2. People all know that currently we can skill patients for 2 main reasons, either therapy or nursing. 90% of RUGs, though, are billed under therapy, actually over 90%, and so it's largely a therapy-driven system. Under RUGs 4, there was quote-unquote one perfect diagnosis, 720 minutes, and that's going to be very different under PDPM. Under PDPM, the system now splits the therapy component into its separate disciplines. So PT, OT, and speech have their own components now under PDPM. And nursing is now split into 2 separate components, nursing and non-therapy ancillary, or NTA, which is the focus of our discussion today. I'll also note that 3 of these components under PDPM, PT, OT, and NTA, have variable per diem adjustments. That is, their payment changes over the course of a patient's stay, which we'll get into for NTA. For therapy, PT and OT, payments will decrease by 2% per week after day 20. So the 5 components under PDPM are very important, but we're going to focus on NTA. This next slide is the last intro slide, and it is a bit of an eye chart, but it shows how payment under PDPM is calculated. Essentially, for each component that we just talked about, there's a base rate that every facility gets that doesn't change patient to patient. It's updated annually every year. And that base rate is multiplied by that component's CMI, or case mix index. The case mix index is patient specific and is the focus of reimbursement, because this is how facilities can optimize the reimbursement, is by getting the highest case mix index for their patients for each component. If there is an adjustment factor, a per diem adjustment factor, as there is for PT, OT, and NTA, that's also multiplied in the equation. And then each component is calculated based upon the product of the base rate times the CMI times the adjustment factor, if there is one. And I would also note that each component's payment is calculated independently of the others. So for our talk today, we're going to focus on NTA, which is a non-therapy ancillary, and the payment calculation is as you see before you. So what is NTA? NTA stands for non-therapy ancillary, and the intention of this brand new component under PDPM is to reimburse facilities for medications, laboratory supplies, respiratory therapy, and laboratory tests, and medical supplies. So under RUGs, this was included in the nursing component, but under PDPM, this is split out as a separate component with its own distinct case mix index based upon resident characteristics. And I think this is a really important component for us to focus on because medications are a very high cost driver of our patient stay, and obviously important for their outcomes. In terms of the variable per diem adjustment for the NTA component, the NTA base rate is calculated first, and then that base rate is multiplied by 3 for the first 3 days of the patient's stay. On day 4 onwards, the facility is paid just the base rate. And the other point I would make is that accurate diagnoses and ICD-10 coding are both critical for appropriate NTA payment, which we'll get into in the next slide. So in terms of the NTA classification, there are 50 conditions and extensive services that CMS has come up with to calculate a patient's NTA score, which drives their case mix index. You see the 50 conditions and extensive services on this slide. And each of these conditions and extensive services is assigned a point. 15 of these 50 have greater than 1 point. You see that if a patient has HIV/AIDS, that's 8 points. That's the highest NTA score condition. If a patient is getting high-level TPN, that's 7 points. But the vast majority of the NTA conditions are 1 point. The the patient's NTA score is calculated by summing up all of their NTA conditions and extensive services, and that puts them into one of 6 groups, each with a different case mix index. Now, just looking at the slide, you can see that you can see why ICD-10 coding and accurate diagnoses are very important. So, for example, there is a NTA category for patients with proliferative diabetic retinopathy and vitreous hemorrhage. So it gets kind of down to not only retinopathy, but the type of retinopathy to that level of specificity. You can see a lot of the other classifications here too, such as the pressure ulcers and different wounds, whether there's the presence of cirrhosis, presence of some cancers, morbid obesity. So it gets pretty specific. And again, the patient's NTA comorbidity score, which drives their case mix index, is the sum of all of their conditions and diagnoses added together. I mentioned that there were 6 NTA groupings, and they are A, B, C, D, E, and F. With each grouping, there is a different case mix index. So if a patient had, for example, 1 to 2 NTA comorbidities, then their case mix index would be 0.96. So that base rate for the NTA would be multiplied by 0.96 times the variable per diem adjustment to get their NTA payment for their stay. In order to achieve the highest case mix index, patients have to have an NTA comorbidity score of at least 12, and that produces a multiplier of 3.25. So what I'd like to do now is just illustrate how the NTA payment is calculated through a case study, which illustrates also the importance of an accurate diagnosis. So this is actually a patient I recently saw within the past few weeks at one of my facilities. She was an 84-year-old woman with a history of COPD and diabetes, transferred to our facility after a hospitalization for severe anemia. She underwent an EGD, because she had heme-positive stools, and the EGD showed esophagitis and duodenal arteriovenous malformations, which were coagulated. The gastroenterologist took esophageal biopsies during the EGD, and on the day of discharge, the pathology came back showing numerous fungal yeast and pseudohyphae consistent with Candida. So the gastroenterologist dropped a last-minute note in the chart saying that the patient should be discharged with fluconazole to treat Candida esophagitis. Now, unfortunately, his note did not make the transfer paperwork, but the fluconazole order did. So when we got the patient, we saw that the patient was on fluconazole, but I had no idea why. I asked our nurse, and our nurse said that when she got a report, the hospital nurse told her that I think she had yeast in her urine. Other relevant factors for this patient was that she had a length of stay of 24 days, which is roughly the average length of stay nationally, not in our facilities, but nationally. And the NTA base rate is $78.05. So I'm going to give you 2 scenarios in the next slide here. One scenario where we assume that the patient was on fluconazole for a Candida UTI, and the other scenario with the diagnosis of a Candida esophagitis, which is considered an opportunistic infection under NTA. So the patient has COPD and diabetes, so that's 2 points each under the NTA scoring rubric. So, and a Candida UTI does not count as an opportunistic infection, so that would not add any NTA points. So under the first scenario, where the diagnosis was Candida UTI, the patient's NTA score would have been 4 points. Their case mix group would have been ND, and their multiplier would have been 1.34. So the base rate would be the base rate times the multiplier, or $104.59 per day. You multiply that by 3 for the first 3 days, and then for days 4 to 24, you get the base rate for a total payment of $3,137.70 if the diagnosis was for a Candida UTI. However, if the patient was accurately diagnosed with Candida esophagitis, which she really had, we would have added 2 points to her NTA score, and she would have fell into the case mix group of NC with a multiplier of 1.85. And you see the math there, but the difference is is about a $1,200 increase in total payment to the facility just for that one diagnosis that was accurate in this case. So I think this case illustrates the importance of having an accurate diagnosis so that our facilities can get credit for caring for the patients that we accept. That wraps up my first section, and I'm going to turn it over to Erin.
All right, thank you. So good afternoon, everyone. Over the next portion of this presentation, I will be reviewing medication management and its ties into PDPM and how the consultant pharmacist and also the servicing pharmacy can collaborate, of course, with our skilled nursing facilities and also our prescribers. So first and foremost, I do have to give everybody kudos on this call because healthcare professionals, we pretty much speak a different language with our terminology, our abbreviations, and our acronyms. Every day, it seems that we add something new to our dictionary. So, of course, we had RUG 4, we had the IMPACT Act last year, and now we have PDPM, or the patient-driven payment model. So kudos to everybody, because, I mean, this could be a look-alike, sound-alike. So just as a disclaimer, make sure we don't mix up the last two letters and make it sound like PDMP, which also stands for Prescription Drug Monitoring Program, which many of the states do use to monitor for controlled substance use. So just going to put that out there. So as Dr. Lynn did say previously, the PDPM model will replace the Resource Utilization Group version 4. It does remove those therapy minutes as the basis for payment. So before with the RUG 4, we had the two buckets with the therapy minutes and also the nursing component. PDPM revolutionizes this, and it puts more of the focus on the resident-specific needs and not the volume of therapy. So the trend has been to make everything in skilled nursing facilities more resident-centered, more resident-focused. We have designed dining programs around resident-specific needs and what they like, what they dislike. We've designed medication paths to be more resident-centered, more resident-focused. So now the upcoming reimbursement model is going to be resident-focused. So everything is moving more to this resident-centered care approach. So like Dr. Lynn said, we are moving to 5 buckets of payment versus the 2. So PDPM does break it down into physical therapy, occupational therapy, the speech-language pathology, the nursing component, which we always had, and then the new component, which I'm going to go into a little bit more in depth, which is the non-therapy ancillary comorbidity score. For my visual learners out there, because I'm also very visual in learning, so you can see with the RUG 4 group, very kind of narrow. The NTA, the non-therapy ancillary component, was addressed under just the nursing component. Did not adequately address variations in cost throughout the skilled stay, which is why under PDPM, they're actually going to break out that specific component and put it on its own. So you can see that it's very more resident or patient focused under the patient-driven payment model. So our hospital outlook, the hospitals are probably going to be discharging more acute patients to our skilled nursing facilities, and our skilled nursing facilities are going to want those more acute residents coming out of the hospitals off of those surgical floors because they will get a higher reimbursement rate. So we definitely need to have a strategy with our customers, our skilled nursing facilities, really looking at over versus underutilization and walking that fine line in between to kind of make sure that we get the most adequate reimbursement possible for each of the residents. If we overutilize, odds are we're not going to match the reimbursement level and we're going to be paying outside of the reimbursement. If we underutilize, will likely result in poor patient outcomes and possibly some reimbursement penalties. So it's definitely going to be a team effort approach, starting with the hospital and the hospital liaison all the way down to the SNF care team, including the admitting prescriber, consultant pharmacist, and the MDS nurse, who is critical to this because she has to enter everything into the MDS herself or himself to get the reimbursement. So like Dr. Lynn did say, so there is 50 conditions that CMS has outlined, extensive service point system. This is the top 5 conditions I think are pretty interesting. HIV/AIDS patients, which is the top one, historically have a NTA component, which is 128% higher than other residents. So for this, there's actually an 18% add-on to the nursing component. But it's also good for pharmacists and prescribers and also nursing facilities, just as a reminder that this condition isn't treated just with one medication. It's normally treated with a combination therapy. Also, some of these medications have to be dispensed in their original prescription bottle. And there's actually about 7 different medication drug classes now that are actually approved by the FDA to treat HIV and AIDS. The next, also in the top 5, are TPN high therapy and TPN low therapy. So high therapy is if a resident has at least 50% or greater of their calories are taken in by TPN. The TPN low is that they have to be greater than 25% but less than 50% of their total calories. Other residents that they're going to be going for are, of course, the IV therapy residents, ventilator respiratory residents, so a respiratory therapist will get in some work. And then it's interesting, after the top 5, the next one on the list is lung transplants. So we really have to get it right as close as possible the first time as the patient or the resident walks in through the door. So that has to occur with the diagnosis, which Dr. Lynn, as you heard, said was pretty critical so that we can get the most appropriate reimbursement. The medications associated with those diagnoses, the care plan, and also the patient goals. What are their goals as they are in the facility? And where the consultant pharmacist is going to come in is to make sure that we at least try to get the right drug right now. So what is the NTA? So as we said previously, the non-therapy ancillary score is a weighted count of certain conditions, which is then used to classify the patient into one of those 6 different NTA payment groups. We did go over the highest scores, and that the skilled nursing facilities will probably take more complex acute residents. And as Dr. Lynn said, there is a variable per diem adjustment factor that goes into definitely the NTA component and also the PT and OT. CMS assumes that higher costs are going to be at the beginning of the stay, so that's why it's multiplied by that factor of 3 for the first 3 days, then reduces down to a factor of 1 starting on day 4. Generic versus brand, CMS, they do not distinguish between the cost differences of brand versus generic. So brand name drugs actually may be a little bit more financially draining. So again, for my consultant pharmacists on the call, we could be experts in this and providing our recommendations on, what could be another option or an alternative to a brand name drug if it's in the same class or another medication that may be as equally effective. So I like to tie things together. We've gone through, as Dr. Lynn said, this is the first, for the reimbursement model, the first major changes in 20 years. And I think long-term care has gone through some pretty significant changes over the past 4 to 5 years. We started with the 3 phases of the mega rule. We're currently in a questionable period with phase 3. And of course, we had the Impact Act that was in October 1st, went into effect October 1st of last year. So I'm going to kind of tie all of these together. These are different buckets that I think can be for pharmacist collaboration and also the servicing pharmacy collaboration, where we can kind of provide our expertise and our recommendations on how to better provide care and medication management to our residents. So the first 2, definitely the facility should look into having a robust formulary or a therapeutic interchange where it is allowable in the individual states. I know different states have different rules and regulations regarding that. That's looking at the efficacy of the medications selected, the cost associated with those medications, and also looking at the nursing administration are reviewed and agreed upon by a pharmacy and therapeutics committee. Limited supplies, so these are definitely probably going to be short stay residents, looking at short cycle dispensing, and also looking at the package sizes of the more expensive products, which are our insulins, our inhalers, and the topical creams and ointments, and making sure that we select smaller package sizes for those. And then I have more detailed slides on IV to PO conversions, antibiotic stewardship programs, so I'll tie that right back into the mega rule. Deprescribing, which is always a consultant pharmacist focus as they go in and do their monthly medication regimen reviews, and then of course medication reconciliation. So IV to PO antibiotic therapy. So in the first 3 days is when the reimbursement rate is going to be multiplied by that factor of 3. So we're going to probably see a large push for getting converted over from, they'll come in on IV and get them switched over to a PO medication more quickly. There's definitely some benefits to switching from IV to PO antibiotic therapy. Of course, is that infection control portion, reducing the risk of catheter or line infection, improving patient comfort and mobility. We don't have to have that IV pull or the IV pump. There's more mobile IV options available now, but you still won't have to have the IV line associated with it. There are studies for decreased length of stay. The all-important, we are reducing nursing preparation and administration time, so our nurses have more time to spend with their residents and provide nursing care. And of course, reduce medication and supply costs. They won't have to pay for the tubing, the flushes, and if there's a pump fee associated with the IV therapy as well. Of course, there's always risk. Always got to look at the benefits versus the risk. So definitely taking the patient clinical situation into account, making sure that they are stable to switch over from an IV product to an oral agent, making sure that their vital signs are stable. The fever is reducing, respiratory rate is stable. They have an active GI tract that, there's no difficulty in swallowing, there's no nausea, vomiting, or diarrhea, and that also that their white blood cell count is improving on the CBC. So consultant pharmacist involvement, I'm also going to kind of include operations into this as well for servicing pharmacies, because some servicing pharmacies do have IV specialty pharmacists that are on staff. They can be consulted as well as the consultant pharmacist. If I poll the consultant pharmacist, I can probably ask them, how many of you get a call from your skilled nursing facilities when reviewing a resident's culture and sensitivity and asking for your recommendation on what to switch to if they want to switch from IV to PO. Because, we are drug experts, and a lot of switching over from IV to oral antibiotic therapy, it's not a 1-to-1 ratio. So Cipro, Flagyl, Levaquin, azithromycin all have IV and PO products, but you can bring a consultant pharmacist expertise into this, and they can review that culture and sensitivity, and based off of the susceptibility on there, they can also recommend an oral agent that could be effective for the infection as well. Antibiotic stewardship. So phase 2 of the mega rule, part of the regulation was for skilled nursing facilities to include a antibiotic stewardship program and incorporate that into the facilities program. So it is under FTAG 881. These are the 3 mainstays of what needs to happen with an antibiotic stewardship. And when we have reviewed recent citations at a national level, and we look at, what are the facilities getting cited upon, and we look at FTAG 881, the major citation reason is they just do not have a program in place. So of course, the first step is to establish a program, have to have a program in place, using protocols and a system to monitor. So the whole antibiotic stewardship wasn't for the skilled nursing facilities to come up with a way to combat Ebola, but to kind of start just monitoring antibiotic use, making sure that the antibiotics were being used appropriately, making sure that they had stop dates associated with them, and that we were monitoring the effectiveness of that program. So where a pharmacist can come into play, of course, is making sure that the antibiotic selection is appropriate. Is it warranted? We come in a lot of times and see that there is still treatment for colonization with urinary tract infections. Black box warnings, especially with the fluoroquinolones, they should have reserved use in uncomplicated urinary tract infections, bronchitis, and sinusitis. So kind of as a last resort, if the resident has, allergies to all other medications, or the bacteria on the CNS is resistant to everything except for those medications, because those medications have been shown to cause tendon, joint, muscle pain. They may cause confusion or hallucinations, and can also cause neuropathy. We are dosing experts, making sure that the dose is appropriate, especially for those who have renal insufficiency. making sure if there's allergies or cross allergies and kind of doing a deep dive there and seeing if there's another alternative for that medication. And then, of course, duration. Very common that we see antibiotic orders without stop dates. So kind of bringing it up to the prescriber or the nurse practitioners, is there a stop date or a duration associated with this medication order? Deprescribing. So deprescribing has always been and continues to be a focus for a consultant pharmacist. I don't have to tell anybody that. So deprescribing is definitely good prescribing. Some challenges associated with deprescribing is that what was first prescribed failed, that we were wrong in the beginning. Sometimes it's a trial and error. I know sometimes we have challenges with the resident themselves and also the family, what they see on television or commercials, or what their family friends are saying. They want to stay on these drugs. They do not want to discontinue them. So it's definitely some challenges as long as some good education is brought about in communication to see if they really need those medications. The benefits, getting them on less medications, because sometimes you come in and you see residents who should be on about 10 to 12 medications get inflated and all of a sudden they're on 20 or 22 medications. The course is to optimize that medication regimen, reduces hospitalization, increases adherence or compliance once they're discharged back to the community, improves their quality of life, and of course, overall just reduces the amount of adverse drug events. So we do definitely want to reduce unnecessary medications. That's also another FTAG regulatory issue that we see. Definitely avoiding polypharmacy, the prescribing cascade where we use some medications to cover up the side effects of others. The most common medications that we see, of course, are the laxatives. We'll have residents who are on 2 or 3 routine laxatives, and then they have PRN laxatives. We're a generation very obsessed with what goes in with our dietitians and then what goes out with the laxatives. Our H2 blockers and our proton pump inhibitors are still on the Beers criteria. Antidepressants, at least probably around 50% of the skilled nursing facility residents do have at least one antidepressant. Antipsychotics, and of course there has been that national initiative to reduce the number of antipsychotics in skilled nursing facilities. Non-narcotic pain relievers, antipyretics, and antiarrhythmics I point out just because a lot of these residents are also on prescription anticoagulation, whether it's oral or injectable. And if somebody is on a non-steroidal agent, such as ibuprofen, may interact PRN with their routine anticoagulants. Just a reminder, it's not just prescription medications. I always like to look at those OTC products, definitely the herbal products and any dietary supplements. Tools to use but not take as an end-all be-all is definitely the Beers criteria, the start-stop criteria, and the CMS adverse event trigger tool. These can be used as a guideline to kind of look at high-risk medications and also look at potential alternatives or other opportunities of medications that can be more safely used in the geriatric population. So just some consequences of polypharmacy and why deprescribing is good prescribing. So of course, with polypharmacy, we have the increased risk of healthcare costs, adverse drug events, at least 1.3 million ER visits per year and 350,000 hospitalizations per the CDC. The geriatric population is 7 times more likely to be hospitalized due to an adverse drug event. So if we can eliminate those as much as possible, we increase the number of drugs we are using. We also probably increase the risk for a drug-drug interaction. Like I said on the previous slide, medication non-adherence, especially when they go home back to the community. They could have a reduced functional status or cognitive impairment, definitely a fall risk, urinary incontinence. Put nutrition on here because if you're taking 15 medications in the morning, you're probably not going to be very hungry. So I know I work a lot with the dietitians to kind of look at the medications as well. And of course, deprescribing unnecessary medications is a regulatory risk. So the IMPACT Act, bringing up another acronym, so the Improving Medicare Post-Acute Care Transformation Act of 2014, which went into effect on October 1st. Two big things for this was to identify clinically significant medication-related issues, which was a pretty extensive list of anything a consultant pharmacist could find in a new admission, skilled nursing admission into a long-term care facility. So it was looking at allergies, excessive doses, adverse drug reactions, durations of therapy. It also does list no indication for use. So going back to how having a diagnosis for each medication is critical, and especially also for PDPM, making sure if we have those ICD-10 codes. The admission drug regimen review, and also the medication reconciliation done upon admission. So just kind of going back to Dr. Lynn's kind of case study as well, just looking at this whole IMPACT Act was to kind of reduce the issues that we see in the transitions of care. So going back to his case study where you looked at the candidal esophagitis versus the candidal yeast infection in the urine, I think the nurse that was giving the report to the nurse in the facility said she thought that there might have been yeast in the urine. So there was kind of a definite miscommunication there. So we really try to improve the communication among the transition of care. So the problems that we do most often see are that new medications are started. We don't know why. Home medications or facility medications that they were on previously in the nursing facility were missed. If it's not on that institution's formulary, they just discontinue it and it's not restarted when they come back into the nursing facility. Old medications are restarted, so they weren't given the most accurate discharge form or medication list when they were sent to the hospital, and then doses have been changed. So there's definitely a lot of issues with transitions in care. We're definitely trying to improve upon them, especially with the IMPACT Act. Some issues that we pretty commonly see are seizure medications not being restarted when they come back to the facility, dementia medications. I actually have one resident that I was involved with a couple of years ago. She was actually a suicidal ideation resident, had post-suicide attempts, and when upon readmission back into the facility, her antidepressant was not restarted. So, I mean, it was kind of a catch. The nurse practitioner was there. It was handled very quickly. So more on consultant pharmacist collaboration. So high cost drivers into what brings up a skilled nursing facilities bill is the type of resident admitted. We know with PDPM and these reimbursement model types that they're going to probably take more acute complex residents. High cost individual medications, really making sure that they price those drugs out prior to admitting them. Specialty medications and IV medications will drive up their costs. Overutilization of medication, so again, tying in the deprescribing format, and of course, lack of having an actual formulary program as well. So where can we help? So consultant pharmacists, we wear many different hats when we walk into the door of a skilled nursing facility. We're very multifaceted in what we do. So I kind of broke it out into 3 different buckets. Definitely not all comprehensive, all encompassing, but we do have a touch on the clinical side, the nursing side, and of course administrative. So clinical, we kind of come in there. We definitely want to make sure that there is an indication for use for every medication. Not every diagnosis needs a medication, but we definitely want to make sure that every medication has an indication, making sure that that dose and duration of that medication is appropriate, looking for and identifying drug interactions or allergies, making sure that the medication is effective. If it's not effective, making sure that we discontinue it according to recommendations and not starting another medication while still having that medication on board. Looking at adverse effects, and again, trying not to add on another medication to cover up a side effect of another and avoiding that whole prescribing cascade. Monitoring, making sure that we're looking at heart rates, blood sugars, any sort of labs, especially with our narrow therapeutic index medications, and all those medications are being monitored properly. Change in condition, always, for me, it's always blame the drugs first. When somebody calls and says, hey, somebody's losing weight, somebody's gaining weight, somebody's having nightmares or insomnia, increased in agitation. I always look at, what drug was recently started, which drug was recently discontinued. Nursing collaboration, definitely looking at administration times. Some drugs are better to be administered in the evening hours versus the morning. Frequency, the stop dates. If there is a manufacturer guideline to administer the medication, that we are making sure that it's being administered properly. Administrative, making we can have a definite hand in medication appropriate selection and make recommendations there. Formulary and therapeutic interchange. I'll point out policy and procedures because TPNs are definitely two of the top 5, so making sure that the facility is properly trained and has a policy and procedure in place on how to take care of a TPN resident. We are definitely there for regulatory guidance and all things pharmacy. And then the non-pharmacological interventions, making sure that those are in place for medication orders such as pain medications and also our psychotropic medications as well. And I'll kick it back to Dr. Lin.
Thank you, Erin. So I just wanted to wrap up by picking up on a point that Erin made and highlighting just the high frequency of patient safety events during the transitions of care. There's been a lot of literature out there about this, and I just picked one article looking at medication discrepancies upon hospital to skilled nursing facility transitions, published in the Journal of General Internal Medicine a few years ago. Previous studies has estimated that 40 to 70% of patients have medication discrepancies upon hospital discharge. Think about that, 40 to 70%. That's over half. It's 47%, but it's a very high number. And in my experience, I'd say that's probably about right. I see probably about half my patients that come through our facilities have some sort of medication error upon admission in their discharge orders. This study found medication discrepancies occurred in almost 3 out of 4 skilled admissions and accounted for 1 in 5 medications prescribed on admission. And so I think there's just a real importance that we perform a thorough medication review. And I think what Erin mentioned before about pharmacists being involved with admission medication regimen reviews is a very important point. So I'd just like to conclude by summing up our presentation. What Erin and I have tried to do during our time together today is explain how NTA under PDPM works and highlight how there is a need for increased levels of both medical staff and pharmacist engagement under this new payment system. Additionally, we believe that the disruptive change being brought about by PDPM creates an imperative for better medical staff pharmacist collaboration, not just engagement, but collaboration with each other to benefit not only our patients, but also our facilities. I've listed a number of clinical and financial benefits of improved collaboration on this slide, and I would just highlight a couple of them. I think first and foremost, improved collaboration will enable our facilities to accept higher acuity patients and take better care of them. We are seeing across the nation that patient outcomes are increasingly driving referrals from our hospitals, and improved medical staff pharmacy collaboration will drive improved outcomes. Accurate and timely medication reconciliation remains critical under PDPM, as I just mentioned, given the very frequent errors that we see during the transitions of care. From this perspective, and admissions medication review on every skilled patient is the best practice, and hopefully one that can be implemented with increasing frequency. I think there's also a real opportunity for better collaboration around helping our facilities obtain accurate diagnoses for accurate NTA payment. I tried to illustrate that with the earlier case study, showing how a candidal UTI versus esophagitis could really impact our facility's payment. And I think one idea for better collaboration would be to have the pharmacist review every diagnosis associated with each medication order. In our facilities, our nurses are usually the ones picking the diagnosis associated with a medication. And, to be candid, I see some pretty crazy diagnoses, things like alendronate being used to treat pneumonia or something like that. And so I think having our pharmacists go through those diagnoses, look at the hospital paperwork, and come up with the right diagnoses associated with each medication order can really help our facilities obtain accurate diagnoses for the purposes of NTA. So I think with that, we'd like to just open it up for questions. Back to you, Bree.
Perfect. And I want to give a virtual round of applause to Dr. Lin and Dr. Foti for this wonderful presentation. I've sat through many PDPM webinars, and every time a new light bulb goes off, and I had many of those moments during this. So thank you for the collaboration that you are providing between a clinician and a pharmacist as we come to this. And as Dr. Lin mentioned, we are going to move on to the question portion. So if you are able to open an additional browser or use your cell phone, please go to aacp.com/QA, and you can click on today's webinar program and see the questions that have been submitted, and you can vote on questions that you would like to hear. So the first question that I'm going to ask our speakers is, well, first, it's a statement. That was an amazing case study, and I would agree to that, Dr. Lin. It's always wonderful to walk through a case study to see how this is actually going to work, and the difference was pretty amazing. And they're just asking for some clarification. Is it 3 days or 5 days to get the NTA payment credited?
So the initial assessment under PDPM is the 5-day assessment, MDS assessment. Actually, facilities have up to 8 days to get that initial assessment in. But that initial assessment is all important because it sets the payment rate for every day the patient is in skilled rehab, unless there is a interim payment update, IPA, interim payment assessment that's done. And so getting all the correct diagnoses, services required, functional scores. There's much more we didn't cover today that goes into that 5-day IPA, but you actually have up to day 8 to turn it in.
Okay, wonderful. And I guess to that point, can an interim payment change an NTA score?
Yes, it can, and there are rules around that. But if there's a change in condition, or if the patient is, for example, sent back to the hospital and comes back, if they say more than 3 days, then a whole new 5-day initial assessment has to be done. But an IPA can change the NTA score. Yes.
Okay, perfect. One question that has been voted up very quickly is how can pharmacists support accurate ICD-10 diagnosis?
I think for that question kind of pings back to what Dr. Lin was saying at the very end, is just going through and making sure that all of our medications have an accurate diagnosis, especially with the EHRs that are out there, and nurses kind of go through, they'll pick a diagnosis, and then we come in there and we know for a fact, like I think you used alendronate treating pneumonia, we know that's not what it treats. To make sure that we write up those order clarifications to the prescriber, making sure that they are accurate, to make sure that those are captured within the MDS as well. And I know that there's other education programs with ICD-10 coding out there. I was just reading the email actually earlier today. And then I kind of just want to point out with PDPM, CMS is a great website also that kind of really kind of details this out, like what he was speaking about with the day 8 and the day 5 and like kind of the interrupted stay and everything. So, I mean, it's all just very interesting as well too. But I think for us with the diagnosis portion just to make sure that, we don't see any outlying medication that has an off-label, or not off-label, just a diagnosis that we know should not be associated with that medication.
Yeah, and I would just add to that. So I think that's absolutely right. The other thing I'd add, though, is the pharmacist's input has to be very timely because if you come up with the right diagnosis for the opportunistic infection on day 9 or day 10, it won't count anymore. So we have to kind of not only get the right diagnoses in, but help our facilities do it in a very timely manner.
Absolutely.
Perfect. To that degree, someone also asked, because diagnosing is out of the pharmacist's scope of practice, how do you recommend pharmacists make recommendations to changing diagnosis when it's inappropriate?
For me, I'd normally put that as an order clarification to the prescriber.
Okay.
As a recommendation to them, just say, like, this medication is currently has a diagnosis for this, can you please clarify?
Wonderful. So another question that's been voted up pretty high is, there's been discussion on the importance of the correct diagnosis when being tied to the drug. What is the impact if the facility has an incorrect indication for the medications? Often the facility will put the admitting diagnosis to all the medications.
And I think that kind of ties back to the fact that they will not fall in the right reimbursement. So, if they enter an inaccurate diagnosis code, then they won't get the proper reimbursement, just kind of like going directly tied back to that case study.
Yeah, cost, I think we said like cost is following care.
Yeah, and I think there might be an out where if the correct diagnosis is found in another part of the medical record. So, for example, if the gastroenterologist note in the case study made it to the facility and there was that diagnosis of candida esophagitis in his note, the MDS coordinator could look in the note and find that diagnosis, even though it wasn't tied correctly to the fluconazole. But I think probably one of the first places to look for accurate diagnoses is the medication list, because by definition, if a patient is on a medication for something, they're receiving active treatment for that condition.
Great. The next question is, at what point will hospitals be held accountable? And I think we can expand on this. This webinar is all focused on collaboration between the pharmacist and clinician, but I think we should also be looking at the collaboration between nursing facilities and hospitals. So how can we be working with hospitals to ensure they are discharging patients with correct indications, correct medications, correct diagnosis?
I think it would just go back to the Impact Act and the reconciliation and making sure with the transitions in care that they, from the skilled nursing facilities, that they're sending the most accurate discharge medication list to them so they have the most accurate information. And then, of course, when it does come back, that they're, mirroring that against what the resident was on before and asking, those questions if there's differences, from the hospital back into the facility or from their home medications to the hospital to the facility, and making sure that there's communication on what those differences are.
It's a really interesting question. There was just this article published in the New England Journal of Medicine this past week called, the title is Post-Acute Care, the Piggy Bank for Savings in Alternative Payment Models. So it's talking about how under APMs, alternative payment models, hospitals often see post-acute care as the primary driver for their success in these alternative payment models. So I think there's a lot of discussion about that and about whether the pendulum has swung too far. But I think from a frontline perspective, all we can do is try to take better care of our patients. We work with our hospitals to help us take better care of our patients. Just as an example, I have a collection of cases of medication errors on the transitions of care, and I have one for most hospitals in our region, and I've been working with the hospitals by showing them kind of how crazy some of their discharge orders are, and it's really eye-opening for them. So I think we will be seeing increased collaboration with our hospitals, hopefully, for better care of our patients.
Perfect. And I'm gonna take 2 or 3 more questions, just because there are a lot coming in. I realize we've gone over our time, but I think the questions that are coming in are really great. So if you are available to stay, please do. Our next question is, I'm a little confused. Facilities will be trying to take higher complexity patients, for example, patients on IV meds, but then we are trying to get rid of those IV meds as soon as possible under the safety and antibiotic stewardship rationale, but won't that decrease the reimbursement?
So I guess to clarify that one, so the reimbursement is highest in the first 3 days of therapy because that NTA score is on there for multiplied by 3, and the condition that for the NTA is a 5. So under the first 3 days, they're definitely going to have higher reimbursement. But I just know just from talking to customers that they'll want to switch them over to PO medications because, I mean, the oral medications for them, I think it's just going to be a fine walk between the reimbursements and those residents. And of course, again, taking in the resident clinical situation to make sure that they're stable. But I mean, those medications are generally more expensive, and I don't want them to have an overutilization. So it's definitely just kind of doing that fine walk with what the utilization actually will be over versus under versus just kind of having a nice happy medium.
Okay, perfect. Our next question is, do you know if software programs are preparing for this? Seems like an opportunity to track and input great data.
So
like the EHR. Yeah,
go ahead.
Go ahead. Sorry.
Go ahead.
Well, I was just wondering if this means like EHR software systems or the actual. I mean, the MDS obviously that's a definite go on as October 1st. But I think all the EHR systems have been doing updates.
That's correct. Yeah. So I know PCC, NetSmart, MyUnity, Matrix Care. They're all doing updates, and they all have kind of their own webinars and focus groups on preparing for PDPM. There's going to be a big emphasis on that in order for them to stay relevant. I know there are also a lot of the consultant groups out there doing webinars and creating software tools for this. I think it all kind of costs money. So there's no shortage of kind of talks out there and information out there and tools out there. I think the challenge is finding one that fits within our workflow.
Absolutely. And then the last question we'll take today, and then I'll move on to directions for continuing education, is how best can a consultant pharmacist be incorporated into the admission process prior to admission and balance workload? Often we are off-site and at other facilities.
And that's a great question. Perfect question. Because, I mean, I think it's almost the same thing as a prescriber. I mean, prescribers are often off-site or at a different facility or at their office. So I think, you know, for us, we're just a phone call away. I mean, I've heard horror stories of admissions where they call, you know, they're like if it's a corporation, they call their corporate nurse and they say, hey, we just accepted this admission, and they're on a medication and they start to spell it out. And they say it's daptomycin, and that all of a sudden we have a patient in here who is, you know, on daptomycin for, you know, 6 to 8 weeks, and they get stuck with the cost of that high dollar IV. So I think as long as like we get a phone call and get to run through those admission meds prior to the admission as well, because I mean, and it's kind of a good reminder to facilities, and like if you can't pronounce it, it's probably going to be expensive. I actually heard that be done at a DON meeting at one point, so it always kind of stuck with me. So I always tell, you know, my facilities, I'm one phone call away. I'd be more than happy to run through any pre-admission paperwork that you could have to run through those medications with you as well, kind of point out, you know, any anything that I might see prior to that resident walking through the door, any changes or recommendations that I can make to the prescriber at that time as well.
Perfect. And the last, it's actually not even a question, but a statement is this was a great webinar. I finally learned so much about PDPM. Thank you. And I would absolutely echo that to both of our speakers today. And I will now move on to directions to claim your continuing education. Please visit our website, aacp.com/webinars to check out our webinars that we have scheduled for the coming months, as well as webinars on demand. Now, if you are a pharmacist, please return to your AACP Learning Center. Click on the My Learning tab, and under Active, you'll see today's webinar, which you used to register for this webinar. You will then take a 6-question test. You have unlimited attempts to achieve a 70% or higher, and this is just used to gauge the content that we provided to you. One of the most important parts is if you are a pharmacist, please ensure that your NABP, EPID, and date of birth are correctly entered into your AACP profile before you submit this evaluation. You'll go through and answer a series of questions. Again, this is just to help us assess this presentation and provide direction for further activities. If you have any recommendations or further questions about PDPM, please place them here so that we can provide that content at a later time. And if you are a medical professional that is looking to claim your credits through AMDA, the directions are here. This should be completed by August 5th if you are claiming continuing medical education. If you are claiming continuing pharmacy education, this evaluation is completed by September 14th. Again, if it is continuing medical education, you must claim your credit by August 5th. You should have received a survey today from AMDA. It's also listed here in your slides. It's listed on our site. And if you have any questions for them, you can contact them at education@paltc.org. Once again, thank you to our wonderful presenters and to everyone who joined us on our webinar today. Have a great day.